today is about what is after BASIL 3. So just to remind ourselves, the CLTI patients usually has an end-stage manifestation of peripheral atherosclerosis, which carry a high risk for limb loss and mortality. And usually the cornerstone for limb preservation is the effective revascularization. And now with the evolving technology and lack of the high quality evidence, still there is ongoing debate about the optimal approach for treatment of those patients. In the past few years, there was emergence of a long-awaited new generations of the randomized controlled data for the CLTI patient, including the BASIL 1, BASIL 2, BASIL-I, BASIL 3. And just to, before going through the BASIL 3, just to remind ourselves with the BASIL 1, which was published in the Lancet 2005, and comparing between the bypass first strategy versus the angioplasty in the critical lower limb ischemia. It was a multi-center randomized controlled trial and included about 500 patients. After 6 months, they found that there is no significant difference in the amputation-free survival between the surgery and the balloon angioplasty. But beyond the 2 years from randomizations, there was a significant improved amputation-free survival and overall survival. And the recommendations after this was the sub-analysis of this paper that the critical lower limb ischemic patients who predicted to live more than 2 years with a good quality vein should be given the options of the bypass first. I know it is an old trial and it was published in 2005, but still a lot of the centers depend on the BASIL 1. BASIL 2, which focus on the infrapopliteal disease, plus or minus proximal infrainguinal revascularization, compare again between the vein bypass as a first strategy versus the best endovascular treatment. And the outcome showed that the best endovascular strategy was associated with a better amputation-free survival, and this was driven by a fewer deaths in best endovascular treatment group. So then we will come to the BASIL 3. BASIL 3 is a part of the series of the trials, and the aim of the BASIL 3 was to fill the evidence gaps regarding the best treatment strategy for CLTI patients. According to the NICE guidelines, there was insufficient evidence to support the use of the drug-coated balloons and the drug-eluting stent in the treatment of the peripheral arterial disease. However, the global vascular guidelines in 2019 showed that the PUPA is still the first line of treatment for treatment of those patients. The BASIL 3 is a multi-center randomized controlled trial on nearly 500 patients, and it divides the patient into 3 treatment arms in the form of the PUPA plus or minus perimetal stent versus the drug-coated balloon plus or minus the stent versus the drug-eluting stent alone. And the primary outcome also was amputation-free survival and the overall survival associated with the cost effectiveness of the 3 treatment arms. During the trial, there was some delay in the recruitment of the patients because of the COVID-19 and the catastasis, which was related to the controversial meta-analysis published in 2018, which leads to that the paclitaxel-coated drug-eluting stent, drug-coated balloons were taken out of use around the world because of the safety concern. However, this mortality signals was refuted by numerous data, including patients-level pooled meta-analysis with 5-year follow-up showed no evidence for increased risk of the death. And then the Medicine and Healthcare Product Regulatory Agency said that this may be a dose-related effect, and they recommend don't use in the intermittent claudications, but can be used for the critical lower limb ischemia patients with enhanced follow-up with the patients. And the recruitment started again in 2019 for the BASIL 3. A lot of the trials also showed the evidence of the drug-coated balloons and the drug-coated stent, includes the IMPACT trial and the Levant and Zelvar BTX. And these trials also showed a higher primary patency over up to 5 years, like the IMPACT trial from Medtronic, and also from Boston Scientific, and also from Bard Lotinix balloons. The methodology of those patients in the 3 treatment arms include median age about 72 years. More than half of the patients are diabetic. Approximately 1/3 has end-stage renal disease, and around 1 out of 5 had tissue loss. And regarding the timing, more than 90% of the patients underwent the revascularizations within 2 weeks of randomization. The result of the BASIL 3 showed that amputation-free survivals was nearly equal between the 3 treatment arms, with no significant difference between the PUBA and DCP and the drug-eluting stent. The major amputations happened in about 14% in the PUBA versus 11% for the drug-coated balloon versus 16% for the drug-eluting stent. The outcome showed that the drug-coated balloons plus the stenting or the drug-eluting stent, when used in the femoropopliteal segment, showed hypothesized clinical benefit over plain balloon angioplasty plus or minus the stenting. Regarding the cost effectiveness, the drug-coated balloons, with or without the stent, is unlikely to be cost effective, according to the NHS willing to pay threshold. The drug-eluting stent, on the other hand, is potentially cost-effective at this threshold, but still there are positives of the BASIL 3. Its power exceeds about 90% with a long follow-up, better even than anticipated, and the cause of the death was available for all deceased patients. And about 35 UK vascular centers were randomizing patients. The message of the BASIL 3, according to the annual meeting in ESCVS and according to the Sharing Cross Conference, that it does not support the use of the drug-coated balloon or the drug-eluting stent in the femoropopliteal segment for CLTI patients within the NHS service. So the take-home message, PUBA is still the most common treatment option in the CLTI patient. Still there are many tools, and this should be an advantage. BASIL 3 results should be confirmed in large population, and we're still waiting for a more clear-cut result. Drug therapy has a little risk to the patient and only can benefit even if they reduce the time to need another intervention, maybe over the next few days or months. As we digest it, the publications come out, and we will have more understanding, and we can apply to our healthcare system and apply to our practice. And thank you.